my talk is focused on a problem that is still an open question, because we are still in between from the problem to protect the patient from thrombotic events and to put the patient at risk for bleeding events. This is particularly important when we have patients who had a first important, the most important bleeding complication, that is intracerebral hemorrhage. Notwithstanding this important event, adverse event, we still have to face with the opportunity to reduce the stroke risk, the ischemic risk of these patients. And we have some conditions that are patients who carry mechanical heart valve that need to be treated lifelong and with anticoagulants, so we cannot avoid to resume anticoagulation. The other two conditions have very high risk for ischemic or generally thrombotic events are patients who had a recent stroke event, ischemic stroke, and patients who had a recent acute venous thromboembolism. Both these patients carry a very high risk of recurrent thrombotic events. But we have a very large number of patients who carry a variable risk of stroke that are patients with atrial fibrillation. So the problem is to correctly stratify these patients and the risk they carry. We had in the last 10 years were published many studies, observational studies conducted in patients with this condition. All these studies seems to tell us that it's true. Patients who had ICH had carry a high risk to have recurrent ICH when treated with anticoagulants. And this risk is estimated in about 5 times more than patients who did not have had ICH before. And what happens? What these data tell us that is this group of patients have even more high risk of ischemic events. So both risk goes up, but not similarly, and the risk of stroke is higher than the risk of rebleeding. But all these data were come from observational studies, and we know the limit of observational study. I think the principal one is that we decide to resume anticoagulation in patients who had intracerebral bleeding, not dramatic. So patients with quite mild events. And we are not sure that this is the same when we if we included also patients with severe devastating ICH. And unfortunately, the recent published data from randomized trials that, it should be noted, are being published only pilot study and first results conducted on a small group of patients are really disappointing. Because observational data seems not to be confirmed. So we are now waiting for more information, and principally from high quality levels data that we will have in the next future, because we have several studies ongoing. And the problem at this moment is still difficult to face, surely.